So before we dive into the findings from our data collection, I thought it might just be helpful to give a bit of an introduction of who we are here at the NHS Benchmarking Network. So we are a UK-wide member-led network, and what that means is that the data within the report and the data that we're presenting this afternoon comes directly from organisations. It's collected and validated. It's not modelled or estimated. And we are committed to collecting data and providing insight for the purposes of collective improvement. It's not about performance management. And for that reason, our members and participants do engage really openly in the collections that we do. We are an independent network, we are UK-wide, and we aren't formally part of the NHS, and what that means is that we can provide a really independent and unbiased view of the services that we benchmark. We've been supporting UK-based health and care organisations to better understand their services through benchmarking and comparison since 1996, and we're really proud to be in our 30th anniversary year. But what that means is that this work that we do across the UK opens up lots of opportunities to better support services and organisations to ultimately improve outcomes for patients. And the work that we've undertaken across the UK really builds on the work that we can do then internationally and starting to look more broader than UK provision and kind of look outside on what's happening internationally. We are the benchmarking network. Benchmarking is what we do. For those of you who interact with us and are well aware of the work here at the network, this won't come as any surprise in terms of, us believing in the power of benchmarking. But for those of you that are new to us and new to benchmarking, what is it? It's essentially the process of measuring something by comparing it with something else. So in this context this afternoon, we're measuring similar types of service provision within the mental health sphere across the world to enable that meaningful comparison. Lots of organisations, lots of services gather data and use that for improvement. But internal data can only show how you are doing, whereas benchmarking enables you to compare and identify blind spots, inspire those improvements and drive innovation. And we're also really committed here at the network in terms of enabling that shared learning, shared networking. So we're really keen for this session, as I said before, to kind of open those doors and make those introductions for yourselves amongst the participants. In terms of the international benchmarking work that we've undertaken and the findings that we will be presenting this afternoon, this is just a little bit of background in terms of the work that we have done internationally on mental health services. The international benchmarking that we do is now in its 4th iteration. So you can see on the table on this slide that we have undertaken 4 rounds of international benchmarking from 2018 through to 2026. And we've had a variety of different countries take part over that time. The benchmarking that we do compares mental health and substance use services across both children and young people services, as well as adults and older adult services. For the 2026 cycle that we'll be taking you through today, we had 8 countries take part, and it's very much a collaboration between ourselves, the Global Leadership Exchange and our international partners. We presented some of this data at the GLE match in Ottawa in June of this year, and it sparked some really great discussions amongst the participants around how we can build on this data, interpret it, and kind of think through what the art of the possible is moving forwards. For the UK countries, this builds on the data that we collect as part of our annual benchmarking project through the network. So for our UK participants, there's no additional data collection. The data is all utilised from the collections that we're already undertaking. But we did do some additional data collections from our international participants between November and December of last year. We then analysed that data and the reports were released in July of this year. The participants contributed data, insight and contextual information, and some of the key themes that we will take you through this afternoon include spending and investment, access and service models, workforce and quality and outcomes. So before I hand over to my colleague Joe to take you through the findings, just a little bit of context in terms of the scale of the data set. So the data that we will be presenting this afternoon comes from our 8 participating countries. It represents 156 million people. 316,000 inpatient admissions across all of the nations, 38.3 million clinical contacts that were delivered across those 8 nations, and $64 billion of expenditure. And again, just to clarify, the data covers both adults and older people's mental health services and children and young people's mental health services. So I'm going to pass you over to Joe now to dive into the findings.
Thanks, Emma. So just to kind of put the lens on in advance, I'm going to just walk through a couple of kind of caveats as well. But throughout this session, there's 4 different ways that we've kind of focused on interpreted the data and kind of pulled questions out and identified kind of areas of thematic relevance, I suppose. And they are the model of delivery, those government priorities, the attitudes towards mental health and substance use services, and that kind of data maturity. And that speaks more to kind of both the data maturity in the respective nations, but also the data maturity as part of this collection and how that's kind of evolved over time. And just before I go into the data in more detail, just some kind of caveats, some notes on how the data can be kind of interpreted. Over the course of the kind of 4 cycles that we've delivered throughout this programme, there have been some changes to data definitions, and that's been based on feedback from participants, which has improved as the kind of collective understanding of the metrics has improved over time. The completeness of the data is variable. Time series data is incomplete for most nations, and that kind of alludes back to that participation slide that Emma shared earlier. But also some nations, just the data doesn't flow in the same way as it does in others. Again, just linked back to what Emma shared earlier, there's been inconsistent participation. So for that reason, we don't interpret this in terms of means and medians. We share kind of the full picture of the nations, and we've got that time series in there as well. And the final one is team changes, and that's both for ourselves internally, obviously teams change over time, but also for participating countries as well. Their teams will have changed, and inevitably what that means is the way that people interpret definitions and things may vary slightly. And just the final kind of point I'd like to leave you with before we go into the data. This is presented as a vehicle to insight conversation and focus on strengthening these metrics, moving it forward. The broad kind of aim of us sharing this data in this forum is to drive this programme of work forward in a way that is sustainable but also useful to participants, and that kind of links in with some of the work that Stephen McLeod from the Scottish Government will share after I've presented the findings. So starting off with finances, and this is just sort of contextual information that sits behind the data collection. When we came to interpreting the data, we looked at what government policies kind of alluded to the proportion of expenditure on mental health services was. And I won't read this out in great detail, but what you can see from this slide is that really varies. There's no kind of consistent measure across nations where you can say, in the same way, this nation is spending X amount or X proportion of their funds to deliver these services. It varies vastly kind of across the participants. But I just feel this is kind of useful context when we come to the next slide, which looks at the kind of investment gap in healthcare spend. And what you can see from this slide is that England spends the largest proportion of its total health budget on mental health services. But when that's translated into kind of a per capita expense, that is amongst the lowest compared to the other participants. Particularly looking at Sweden and New Zealand, who spend comparably more money per capita on these services. And what that tells us is that a high share of the budget doesn't necessarily translate into kind of high investment per person. So the next kind of couple of slides look at the front door effectively, so community services, where people generally interact with mental health services first, and just kind of trying to get to understand whether does the number of patients seen capture the quality of care. So starting here with kind of generic adult services, you can see from the slide here that Sweden sees 3.4 times more patients per 100,000 population than Wales, for example. And all countries, if you look at the time series here across the bottom, have shown growth since 2018, which is consistent enough to point to kind of a genuine increase in demand rather than a reporting change. What the question that this kind of draws out is whether systems are still built for that pre-2018 demand level, or whether we are now kind of adequately resourced for, one, the demand that is evidenced through this data here, and two, what the demand is likely to be in the future. So moving on to the contacts and delivery mechanisms in adult services, there's kind of two positions at opposite ends of the charts here that deserve attention. Australia has the highest contacts per patient at 25, but the lowest face-to-face rate at 38%, whilst conversely Scotland has the highest face-to-face rate of patient contact at 84%, but only delivers kind of 9 contacts per patient. Now, these aren't just necessarily different numbers, they reflect what is likely a fundamentally different philosophy about what contacts within a mental health service should look like. And then just drilling down into that a little bit further, into that kind of face-to-face contacts as a percent of all contacts. What this time series captures is how different systems have responded to the pandemic. So the data here suggests that Sweden seems to have adopted a non-face-to-face methodology delivery, as has New Zealand and Australia, where England appears to have adopted a more kind of hybrid model. And these choices now obviously define kind of the structure of care for millions of patients. And the question that this kind of draws out is whether or not this is still a proxy for kind of care quality. So can we still link this to outcome measures in the way that perhaps we have historically? Moving on here to children's services. This broadly kind of mirrors the adults pattern, with Sweden again leading on patients seen per population, but the gap between nations here is less extreme, which may reflect kind of those consistent referral thresholds. But Sweden does see the greatest demand per population, which is and has seen a kind of a notable uptick over time, where Ireland, New Zealand and Australia have maintained relatively consistent demand across the cycles of reporting. And then again, touching on the contacts and delivery mechanisms, Ireland's combination of the highest contacts per patients within these services and the highest face-to-face contact delivery mechanism in children's services points to that kind of intensive relationship-based model of care, whilst England's position at the kind of lowest face-to-face rate raises an important question about whether that reflects a deliberate hybrid model or a system kind of trying to cope with demand with increasingly limited resources. So in summary, from that kind of those community metrics, what this kind of points to is two kind of distinct models. There's those systems that have adopted kind of high throughput systems. So Sweden, England, Scotland, and Canada. They see over 5,000 patients per 100,000 population, with on average 9 contacts each, while high intensity systems like Australia and New Zealand see about half that, with a much larger number of contacts, averaging around 22 to 25 contacts each. And what I'd kind of invite you to consider is whether that feels, whether that matches what your experience is on the ground, if you like. Does this picture feel like something that is a design choice, or something that's sort of emerged by default, given the kind of ongoing demand that these services are having to cope with? So the key kind of questions that we've pulled out from this is, has the shift to a hybrid delivery impacted patients? And that's something that we will only be able to tell in kind of the fullness of time. Is the shift to a community-focused care less evident than some countries would expect? And you'll be able to kind of understand that a little bit more as we pull out the data in the inpatient section, which I'm going to walk through next. Is demand really increasing at the rate we believed it was? There's plenty of hyperbole in the media about increasing demand, both across adults and children's services. And is that translating in the way that you maybe would have expected, given the data that we've just shared? And in terms of that data maturity, and it's a question that we are asked on kind of regular intervals, how do we measure what a meaningful contact is? And different nations and different jurisdictions will have different approaches to that. So it is worth just kind of treating some of this data with an element of caution. So when the next few slides, we're moving on from that kind of community picture and looking to where the pressure is kind of most visibly acute, which is inpatient care. And the core tension that I want you to kind of hold on to while we work through this is both that too many beds at low occupancy and too few beds at high occupancy represent a system that's not operating in quite the most functional way. So starting with those general adult psychiatry beds, which is the definition we've adopted within this programme of work. And when we share the slide deck following this, the definitions that I've kind of touched on for these metrics is included as an appendices, but I won't present that today. And again, Australia and Wales represent opposite poles in this data. So Australia has the highest bed footprint and the lowest occupancy, where Wales has the lowest bed footprint and the highest, with most systems operating at or above the British Medical Association's recommended safe occupancy threshold of 85%. And the majority of countries have almost kind of no buffer for any sort of unexpected demand. And what I've kind of pulled out on the slide as well here is that mean lengths of stay have not changed materially over the life of the collections. There's a couple of kind of anomalies in there, but in general, they seem to have kind of stayed sort of the same. And again, I would open the door to challenge here. Does that feel accurate? Does that feel like what it feels like to those of you who are actively commissioning and delivering these services? Looking at that older adult psychiatry bed, again, Scotland's position here is as the highest bed provider in older adult psychiatry, alongside a relatively low occupancy, combined with those shorter lengths of stay, kind of point to that a throughput model rather than one built around those sort of sustained therapeutic relationships. The occupancy rates here generally are lower than in general adult services. And again, I'm open to the challenge of whether or not that is what it feels like on the ground. In terms of long-term care and rehab, bed provision strategies do vary internationally, and though the trend appears to be kind of a lower number of beds of this type, and it's likely reflective of genuinely different national philosophies about whether long-term residential care belongs inside these systems at all, occupancy rates are held similar to what we've seen in adults and older adult beds. But again, as you can see in that kind of those lengths of stay, this is fairly not quite as well populated as the other two data points that we've just touched on. And then looking at children and young people's psychiatric bed units. So what we can see here is the children's inpatient provision shows the lowest occupancy rates across all of these service types. But I would caution against reading that as sort of capacity to spare, and I'm sure many would echo that. CYP inpatient admissions tend to be for the highest, kind of most acute complex cases, and low occupancy may simply reflect how few beds exist for those deemed suitable for admission, rather than how many are truly available. Occupancy rates are lowest across services, and there doesn't appear to be kind of any meaningful relationship or difference that's obviously driven by those bed stock footprints. And just reflecting back on my questions about that kind of balance of care, it's worth noting here that Sweden reports seeing the most patients in the community, but then also reports fairly short lengths of stay in a relatively low kind of bed footprint. So in summary, there's kind of the story here is one of capacity and flow. There appears to be limited slack across all systems, with most operating at above 85%, which is the recommended kind of safe occupancy rate from the British Medical Association. That rate may vary from nation to nation, and jurisdictions may have different policies on that. And then the kind of community versus inpatient, as I've touched on, there's kind of limited coherence in kind of approach and how they join up. So whether those kind of more intense systems have a lower throughput in inpatient services, there doesn't seem to be kind of a genuine statistical link between those two things, which does kind of raise the question whether, well, I suppose two questions. One, whether community focused care is the better model that we are kind of leaning towards, or whether it's more a question of whether those community services are being delivered in quite the right way to capture people at the right points and kind of lead to prevention of those admissions. So the key questions that I would kind of like to leave you with from this section is, do countries with shorter lengths of stay have more robust community services? Now, what we can't necessarily tell from this data, and one of the things that we don't necessarily touch on too much, is that kind of qualitative data. So looking at what that pathway looks like, and we don't necessarily know how we could join that up. And that's one of the questions I would kind of like to pose to the group today. Does higher bed provision reflect greater needs, different care models, or historical infrastructure? And that is a question best answered locally. That's not necessarily one that we can answer here, but it is something that we can kind of point to the data and see where that makes sense. How can we further explore whether a community-centred approach is leading to improved outcomes? And I'll touch a bit more on outcomes in a moment. And then, again, just touching on that kind of data maturity as with the thought of kind of how this programme will continue. We've obviously got those kind of couple of bed definitions, and again, I'll share those post this meeting. But do they really map? Is that a genuine kind of map to what's actually operating in systems? And I welcome the challenge on whether or not those definitions are correct. So open to feedback. So the kind of final section of this part is just to look at equity and outcomes. And it's important for me to point out kind of before I share this is where the data is thinnest, and I don't suppose that will come as a surprise to many on the call. Outcomes and equity, and the incomplete nature of the data here is itself one of kind of the most significant findings from this piece of work. What we discovered as part of the match is there are really good pockets of practice about patient level outcomes, where that's captured appropriately and correctly in the systems that are in place to do that. What that's not necessarily translating to is joined up ways of kind of capturing that at like a data level where you can share that progress and compare in a meaningful way. So what's come out of this is only 4 of the 8 countries in this collection could submit any outcomes data at all. And of those 4, outcome completeness ranged from 19% completeness to 54% completeness, which means that for the majority of patients across all of these systems, there's no real record of whether the care they received has made a difference. It is also worth noting that we don't look at the outcomes of the system, which I think is something Stephen's going to touch on in his presentation about the Scottish Government's approach. And what I mean by that is system level outcomes, like where a government has or a jurisdiction has an aim to, for example, reduce waiting times. We don't capture whether or not those initiatives are successful. And that's something I'd like to explore as kind of the development of this programme of work, whether that would be something useful and whether that's something that would genuinely be comparable as well. Okay, so bringing that kind of sharing of the data to a close, I want to kind of pose a couple of questions before we answer some of the questions in the Q&A. The first of which is, how can we build on this data set? And what we'd really like to do is listen to the network, listen to everyone on the call and anyone who's has a vested interest in this, and understand what would be useful. We've got some feedback from the GLE matching Ottawa, and we're drawing on our own network as well as the GLEs to kind of bring more feedback in. And to provide that feedback, there will be an opportunity towards the end of this webinar, but there will also be a survey shared afterwards where you can kind of offer us some kind of qualitative feedback when you've had a chance to mull it over. We are, as I've committed to, we're going to share the definitions that I've alluded to throughout this, and that we are really open to challenge on those. We are ready to kind of consider those in partnership with the nations that want to participate to ensure that everyone is truly getting the value that they can recognise from this. And a kind of broader question, what we don't factor into this is the exploration of prevalence that sits behind the demand and the capacity that's kind of exercised to meet that demand. And it's an open question, is that something that we could do? We have data in the UK that we could feed into that, but I don't know what that looks like internationally, so I'd be really interested to understand if we could feed that in and whether that's something that we could use to kind of colour in some of the blanks that sit behind this data and contextualise it a little bit more. And then what is the route forward for this programme of work? So we've always kind of iterated this in a very similar way. We've done a data collection, we've shared a report with participating nations, we've shared it at GLE matches, and then we've generally hosted a webinar not dissimilar to this one. We've had lots of interest in this. I think there were nearly 300 people registered for this event, and then there's another 100 or so registered for the one tomorrow morning. And I just would like to test the waters. Would people be interested in receiving an international newsletter? We've got lots of opportunities where we could gather case studies from work that's going on in lots of different nations, from connections that we've made in the GLE, but also just from our own networks as well. Whether alongside that newsletter, and I'm seeing lots of thumbs up, so I'm hoping that means that's a good idea. Whether a more formalised network would be something that would be of interest. And by that, what I mean is maybe a space where you could log into and we could share case studies, have discussion boards, share some of this data and offer opportunities for other nations to kind of contribute things that would be of interest to them. And then finally, as you've seen in kind of one of the earlier slides, we've run this kind of intermittently over the last couple of years. Based on when the GLE match was, we chose to pause it during the pandemic for kind of obvious reasons, the pressures on the various systems involved. And whether or not we could kind of turn this into a more sustainable project that runs annually. And by that, I don't necessarily mean it needs to look exactly the same. So for example, next year we could do what I've described and look at those kind of prevalence figures. We could do kind of a qualitative data collection and help countries interpret where their pathways are similar, where they diverge. You know, there's the possibilities are endless, I suppose, is what I'm trying to say. And within the discussion at the end of this webinar, I'd really invite people to share what their ideas or preferences might be, but also in the survey that you can click here, you should be able to click on that link and complete it from here, but I will share it again in a kind of follow-up email. And if you would like to just talk to me a bit more, if you're not bored of listening to me talk for the last half an hour, I've put my booking link on there as well, so I'm more than happy to have a discussion with anyone who's interested in this programme of work or has ideas as to how we can make it more sustainable, more interesting, more useful and more strategic for participants. So that brings me to the end, I think, Emma.
Lovely, thanks, Joe. There have been a couple of comments in the chat, and we have had one comment and question added to the Q&A. Just a reminder, the Q&A facility is there if you'd like to use it. The question was, demand reflected in this data cannot outstrip resource, so the demand can grow in a country without it being reflected in the contact data. And we did have discussions, I think, around that, Joe, didn't we, when we presented this first, that kind of demand, we quite often kind of measure demand by referrals or activity, but actually that isn't necessarily the right measure to be using. So really interested in thoughts around that.
No, that's really a good question. I think like you're right, what we are kind of capturing is the demand that is kind of falling on the system. What we're not necessarily capturing is the kind of broader demand, and that's why my kind of question focused around prevalence is I think a really fundamental one, and why it would be really useful to colour in that gap in this data collection, and see what that looks like more broadly. So yeah, a really good question, and something we can kind of factor into the forward planning.
Yeah, and another question that was part of that was, do we look at waiting list growth? I don't think we do we, Joe?
No, we've not looked at waiting lists as part of this collection, but that is not to say that we couldn't. I suppose what we're at the mercy of is when we share the kind of specification in advance with our partners and participants, whether the data flows in a meaningful way that is comparable. Now, within our kind of data collections, we do look at kind of waiting lists, particularly in CYP services, but what we don't necessarily capture is that internationally. But again, not to say we couldn't.
Lovely, thanks, Joe. A few messages in the chat as well around complexity, explore how complexity can be measured, and also looking into deprivation as well. And again, we did also have lots of discussions again when we presented this data previously around how kind of the geography of a nation does have an impact in terms of how services are delivered.
Yeah, and it's really interesting when we kind of unpick that a little bit more, because there's similarities in systems that you wouldn't necessarily expect, and that is driven by that kind of urban versus rural kind of makeup, but also driven by sort of population size, and that I suppose is the reason for my question around prevalence. Would we, if we were to look at a much smaller nation, would that translate in the same way to a larger nation? Would the prevalence levels kind of look the same and feel the same, and would they be what we expected? I suppose is a really good question to colour it in with.